Yeah, thank you. I'm going to try to share the screen. Do you see the screen?
Yes, we do. Yeah.
Excellent. So thanks for the invitation to talk here, and I'll talk about other things you may see in chest X-ray when you do tuberculosis screening. These are my disclosures and a bit of the background. In the slide that Guido showed in the previous presentation, it all started in 1996 with research. That was my PhD. I was hired as a PhD student, made the first version of what later became cut for TB in the previous century, and it was eventually brought to the market in 2014. And I'm really proud of how widely it is used now. But I've been heading a computer-aided diagnosis lab at multiple universities, and I've worked also in other areas of AI in radiology. So I want to talk today about, first start with what is available currently for chest X-ray in the Western setting and how that is going, and then emphasize that TB screening is really a completely different setting. And then focus on attempts to identify other abnormalities in chest X-rays than just TB. Talk a bit about screening principles and focus a bit on one of the possible applications, lung cancer screening. So we have made a website in the Netherlands of all the AI products that are on the market today for radiology, and it's a nice website to go there if you want to see what kind of software is currently available. And there are already almost 230 products available, CE certified for AI in radiology. And here you can also choose different subspecialties. So if you choose chest X-ray, you see that there are now 31 products available that analyze chest X-rays. So too much to show all. But the trend really is, and I'm highlighting this here with one particular software program, to try to detect all abnormalities you can see in a chest X-ray. This is software from an Australian company that detects 124 different findings on chest X-rays. And where this is going is that these companies are now actually starting to also write the radiology report. And then this is in a Western setting where there's a lack of radiologists and an enormous amount of chest X-rays to report on, something that could really improve efficiency. However, you have to realize it's not really there yet. We have done in our university group a study published last year where we looked with another software from Lunit, if it is possible to automatically write a report that a case is completely normal if the AI systems do not detect any abnormalities. Because then potentially radiologists will no longer have to look at these normal exams. But we actually found that if you want to not miss any abnormalities, you have to use a fairly low threshold, that you could only reduce the workload for radiologists by 15%. But still 15% is a good start. And I think slowly but surely, when AI would further improve, more and more chest X-ray exams in a Western setting would no longer have to be reported on by a radiologist. Given the shortage of radiologists, that's an important development. But going now to TB screening, you have to realize that TB screening with chest X-ray is a completely different setting. We're not looking at two views. We're only looking at a posterior anterior single chest X-ray. We don't compare to prior images. And in the case of TB screening, suspicion for TB is really the primary output of the exam. If you look at scoring systems that are used in TB screening, then very often the readers would also report cardiomegaly and the presence of other abnormalities, because if the person would subsequently test negative for TB, but there is an abnormality on the chest X-ray, you have to do further research to find out what's going on. But that's it. Although complex systems exist, here's an example of a system from Cape Town, where you can indicate all kinds of other abnormalities as well. In practice, these systems are not widely used. So you could actually wonder what the use is of detecting these other pathologies. But as I just showed, that there are now systems on the market that detect multiple abnormalities. Of course, people have started to test them out in the context of TB screening. And this is a recent publication that looks at 3 different packages and then draws the conclusion that the findings alleviate ethical concerns of missing abnormalities other than TB. And it would show their broader applicability. But actually, after reading this paper, I doubt if this is a conclusion that you can draw. But let's look at what they did. They took images without chest X-rays, without TB. It was from Germany, where there is very little TB. And then they looked at the other abnormalities that were present on these X-rays, and they let radiologists read these cases. So they indicated that these findings, these abnormalities were present on a certain subset of these images. And then here you see the sensitivity and specificity of these 3 software packages that were analyzed in this study for these various abnormalities. And like I said, cardiomegaly, I think, is a useful one to report on. It's commonly done in TB screening. But if you look at the sensitivity, it's actually quite disappointing. 55% specificity, 97%. 47%, 51%. So this is something to be aware of, that if it finds a lot of abnormalities, for all these abnormalities, you have to wonder how accurate it really is. And in fact, we did a study a couple of years ago where we looked just at detecting cardiomegaly. And we also checked how well radiologists could do that. And on this data set, you see that radiologists achieve an area under the curve of 0.98, which means that, they have both sensitivity and specificity in the, around 93, 94%. Now, why do radiologists not have perfect result? Well, the cardiothoracic ratio, which defines cardiomegaly, you will always have borderline cases, right? The threshold is 0.5. So if you have a case which is just borderline cardiomegaly, one person will measure a little bit longer line than the other person. So you will always have inter-observer variability. But it's actually possible to do this with over 90%. And what you see here in the blue line is the result of our software, which is working just as well as radiologists if we actually find the heart and the lungs and do the measurements with the software. So we segment these structures and do the right measurement. But what most commercial software does is just take images with a label, cardiomegaly, yes, no, train a neural network. And what we show here is that you get, worse performance, but actually a bit comparable to what was done by these 3 other packages, around 50% with high specificity. That's the green line. But the segmentation method, we trained with only 600 images, and this green line was trained with 60,000 images. So it's much more difficult for a network if it doesn't get exactly the location of the heart, of the lungs, but just the label to give good performance. And actually, I think, therefore, you have to be very careful if you want to find all these different abnormalities with a single network. But still, I mean, it is what these packages provide. And you have to realize also that for most abnormalities, you have either not too great sensitivity or not too great specificity. So if you run that on an X-ray, you will almost always find something, and it's actually likely to be a false positive. And you have to wonder, what would it mean clinically if you see a calcification on a chest X-ray? Well, actually nothing. It is something that a radiologist should report in a radiology report, but most of these things do not have a direct influence for a patient, maybe with the exception of pneumothorax, which is, of course, very rare in a TB screening setting, but actually the software is doing quite a good job there. Also, if you look at the relation between these findings by the different software and the actual diagnosis, well, in this paper, they also say that atelectasis is a diagnosis. I would not agree with that, but you see that there is a different relationship with it, but it is definitely not that you're immediately making a diagnosis. So I think this is important to realize. Because if you do additional things in a screening setting, you really should go back to the basics. And this is the old classical WHO study from the 1960s that talks about under what conditions should you do screening. And there are a couple of requirements there. You should only do screening if you're looking for an important health problem. There should be an accepted treatment. You should be able to treat the patients that you detect. There should be a latent or early stage, because if you detect the disease only when it is completely evident that it is there, then you can just as well not screen and wait until the patients go to the doctor. There should be a suitable test, acceptable to the population. And in the end, the cost of screening should be balanced with the expenditure of the medical care. So it's really cost-benefit analysis is very important. Otherwise, you're just going to find cases that should not be treated, and that is quite risky. So if we now look at an example of a disease that people are suggesting we could look for on X-rays made during TB screening, namely lung cancer, we can go off this list and see if it is really worthwhile to screen for that. And then actually you should first consider in your population that you're screening for TB, is there actually a lot of lung cancer available? Because really this is only prevalent under older people who have been smoking or are still smoking a lot. And that's not always the case in TB screening. It is the case, though, that lung cancer, if you detect it early, you can sometimes treat it. So there is an early stage that you could presumably detect. But then you have to realize that in a lot of countries where there's a lot of TB, there is not the possibility to diagnose and treat patients because you have to do, in the end, a lobectomy, which is very advanced thoracic surgery that's not always available. And otherwise, you have very little to offer to people with potential lung cancer that you have detected. Moreover, chest X-ray is known not to be a good test for lung cancer. So CT, on the other hand, is a good test and is recommended, but the lung cancer, chest X-ray screening for lung cancer is not recommended. It will lead to a lot of false positives and necessary follow-up. Just to illustrate that, this is a CT scan, and here is a nodule. This could be lung cancer. This is something that you might want to detect earlier, but you see it very well on a CT scan. But if I make the slice of the CT scan thicker, this is 3.5 millimeters. If I've cut 3.5 millimeter, now it's already difficult to see this nodule. If I make it 7 centimeter or 10 centimeter, it's impossible to see the nodule. So this is why chest X-ray is generally not recommended. When you see a nodule on a chest X-ray, it's already bigger than this, and then it might actually already be a metastasized lung cancer, which is not curable. And that's really the balance you have to deal with in screening. On a simulated X-ray here, you really cannot see that nodule. As a result, the guidelines, this is a guideline from the NIH, really advise against using chest X-rays because it doesn't work for lung cancer screening. This has been analyzed in a very large study published in 2011. And they found that chest X-ray screening simply did not lead to lower death for lung cancer. On top of that, they have done a very big screening in the US with CT, and there it was shown that this actually works for lung cancer screening. But in that trial, they used a group for chest X-ray as the control group because they know that chest X-ray screening for lung cancer doesn't work. You have to keep that in mind. So I'm a bit skeptical there, and I think you should really be careful in interpreting the data. This is a recent publication from a study from Vietnam where they tried to do lung cancer screening within TB screening. And they showed that after screening 136,000 subjects, they detected people with malignant lung nodules, but in the end, only 133 were diagnosed with lung cancer. And that is 0.1%. Well, actually, in the lung cancer screening, it is common to find lung cancer in 1%. So this shows that within a group of people that you screen with chest X-ray for TB, you will generally find very few lung cancers. But of these 133, only 84 were treated. Presumably in the other cases, the lung cancer was already so far advanced that treatment made no sense. And what they don't report is how many of these 84 people, so 0.05%, were actually successfully treated in the sense that they had a good survival after this treatment. So I think we have to be very aware of that when we're going to find other things, that you basically should only screen for important health problems which can be treated, and if you don't cause too much harm. So most of these additional findings that this screening software could detect has no clinical relevance, and in fact lung cancer screening with chest X-ray is not recommended in general. And given the fact that often treatment options are not widely available if in areas where you do TB screening, you really should only consider looking at lung cancer, in my opinion, if you know that there is a high incidence of lung cancer in your screened population and you have treatment options available. Thank you for your attention.